I love that last session so much. I don't know what it would be like to have Olga Kazan watching everything I did for a year, but I know that Olga also spent some time with you and wrote an article and said, spending time with you is like eating a firecracker.
I don't know if that's a good public health message, but...
She said eating a firecracker in all the best ways, that it makes you feel smarter and better. I just want to put it on the table because it's sort of in my mind. Leana, in terms of what you do in looking at the scene in Baltimore, how do you look at it? What do you see as the health picture? What's positive? What's negative?
Well, the health picture itself, and I don't have any slides, although I think you might get a slide later showing life expectancy based on geography in Baltimore. If you were to look at almost any map that we can present, it'll be the same. As in, I can almost replace the legend with anything else, right? This slide, for example, you have life expectancy, but if you replaced that life expectancy by infant mortality, cardiovascular disease, addiction, untreated mental health, poverty, education, crime, I mean, it's the same map. And I think so often we get bogged down by thinking about how health is tied to everything else. I mean, we know that, and I certainly think that studying the social determinants is a good thing, and understanding it is a good thing. But we also have to not feel overwhelmed by all of this, and to say, look, there is something that we can do right now. From the public health side, that involves, for example, identifying where the data are, right? What are the data? What can we focus on objectively as this is the place, this is the primary outcome that we're studying, this is how we're evaluating it, being single-minded about that North Star, and then also focusing on saving lives. We were talking about addiction in the last panel, and we saw in this city that we have an unprecedented number of people dying from overdose. Last year, there were over 700 people who died from overdose. And in our city, what we did was to issue a blanket prescription, this standing order for every single resident in our city. Writing a prescription for 620,000 people was a little scary. But you know, as a result of that blanket prescription, as a result of our doing over 40,000 trainings, we saved over 2,000 lives.
Not to interrupt, but how does that work? Like, I read that you had done this blanket prescription and people were celebrating you. Is this not done in other places? Is it done in other places? And when you write a blanket prescription, how does that technically work?
We worked closely with our state legislature, and I know that there are several of our legislators in the room. Delegate Dan Morheim is here as an example. We worked closely with our state legislature. Is he
a good guy or bad guy?
A wonderful partner and a fellow emergency physician.
Great.
Who is very dedicated to the same issues about addressing addiction and promoting health equity. But I issued, as a result of the state mandate, as a result of the state law, I was able to, 2.5 years ago, issue a blanket prescription to every resident in our city, which means that naloxone, or Narcan, the opioid antidote, is essentially available over the counter. Now, other places have done this too, but what we know in the city, and again, based on a core public health principle, is that policy alone is not enough, unless we also have the services to meet people where they are. And that's why we have teams. We work closely with our community groups, with our outreach groups, STAR. I see Reverend Deborah Hickman here. I see Kevin Lindemuth from Healthcare for the Homeless. It's just a few examples of the wonderful partners that we have who help us to get naloxone into people's hands. And that's why everyday residents, not counting police and paramedics and first responders, everyday people have saved, as of last count, 2,072 lives of fellow residents in our city.
You know, the map has disappeared, but one of the things the map was showing is in various pockets within the Baltimore area. Folks, if you hear this, feel free to put the map back up. But you see an incredible, almost 20-year disparity that does track with what you said, that the wealthiest areas of Baltimore, you know, have a life expectancy 20 years greater than you know, those with the less socioeconomic levels. And I'm just sort of interested when it comes to introspection and self-awareness. Does the community, do the stakeholders, is there awareness of what's going on within these pockets?
I don't think that the statistics would be surprising to individuals living in the communities. I mean, when we go to community meetings, when we talk to neighborhood leaders and faith leaders, they'll tell us what we see. Maybe not necessarily describing exactly what is the cardiovascular mortality or the number of ER visits due to addiction and mental health, but this is not a surprise to anyone. The problem is that we cannot just be giving data to our neighborhoods and saying, here are the problems in your neighborhoods, unless we also come and say, here are some things that might work, that have worked in other places. Here are some resources that we can offer, but also critically say, what is it that you need? Because we can't just be, part of what's frustrating about public health is that we are focused on these long-term goals. And these long-term goals are important. We have to study life expectancy and all these other things that I mentioned. But if we only had long-term aims, when is the community going to see any impact of our work? And so our work very much is about asking the community, what is it that we can do right now? What are the issues that you're seeing? You'll hear from one of our partners in the city later, Holly Freistadt, about food policy. That's something that we hear all the time. I'm an ER doctor, and in the ER, I can tell my patient with heart disease, eat healthier. But how can they really do that? Or what am I really saying to this patient if she then says to me, but I live in an area where I have to take 2 buses and then walk 10 blocks, and by the way, it's a Whole Foods, and I can't afford that. I mean, what are we saying to our residents if we're giving solutions that are not within people's reach?
One of the things that struck me about Kiara who was up here was, and from the moment I first met her in the green room, is this brightness, this positive side. I think it's part of the article that Olga wrote, amidst some pretty tough circumstances. How much do you, I hate to ask this, but does bleakness draw things down? Do you need to sort of find a way to give people sort of what Kiara has, which is a self-image, an aspiration that things can be fixed? Is that part of the ecosystem that you're trying to fix?
Absolutely, but I think that ecosystem of optimism and hope and courage exists everywhere in Baltimore. And I really hope that people see that. I mean, I love Olga's reporting. I think that story is important for us to tell. But I think an equally important story is the work that's being done every single day. I mean, I'm so proud to work at the health department. I have 1,000 employees who are from the communities that they serve, who work every day as community health workers teaching about the ABCs of safe sleep. I have individuals doing home visits every day to prevent lead poisoning. We have many people who work on our needle exchange vans who are in recovery themselves. I mean, they're such incredible people who are inspiration because of who they are, but also because of the work that they do. And we have the data to back it up. I mean, as a result of our home visits for safe sleep and delivering cribs, we've reduced infant mortality in our city by almost 40% in 7 years. As a result, thank you, as a result of needle exchange, which we started in Baltimore 25 years ago. We were one of the first jurisdictions in the country to do that. We have reduced the percentage of people with HIV from IV drug use from 63% in 1994 to 7% in 2014.
Wow. So you have a $130 million budget. How much do you need beyond that to actually win on all these fronts, or do you have enough?
If any of you happen to have 130 million more, I would welcome it. But
I mean, I guess the question is, do you have the resources that you should have to tackle the challenges you have? Is it enough? I mean, I hate to put dollars on it, but dollars matter.
We do not have nearly enough resources, and the resources that we have are threatened every day. It's been said that public health saved your life today. You just don't know it. And in fact, public health often works when we're invisible, right? You don't hear about the restaurant inspections we did in order to prevent food poisoning, but you do hear about the one case of E. coli or salmonella or something, right? Or you don't hear about the work that we do to mediate violence, to mediate conflicts, to prevent a gunshot wound, but you certainly hear about the gunshot wound or the gunshot victim when it occurs. And so I think one of the challenges in public health is, how do we make the case for prevention? How do we make the case for these upstream interventions, right? How do you make the case that housing, for example, is healthcare, as my friend Kevin often says? And so one of the lessons that I learned is something that Congressman Elijah Cummings likes to say, which is that we shouldn't just talk about the cost of an intervention. We should talk about the cost of doing nothing. Gutting Medicaid, gutting children's health insurance program. I mean, these are things that were up for debate in the last year. Some of you may know I have a 9-month-old baby, and my pregnancy almost entirely coincided with all these attempts over and over again to repeal the Affordable Care Act. And I kept on thinking when I was pregnant, how lucky I am that if my doctor says, get an ultrasound, I never had to think about what's the alternative. Do I pay for this ultrasound that may save my baby's life, or do I pay for food and rent for the rest of my family? I mean, these are the challenges that we have to think about every day. And it's really disappointing. I mean, my agency found out about a year ago that our teen pregnancy prevention program, which is evidence-based, science-based education in middle schools and high schools, that program was going to be cut entirely with a loss of $3.5 million. It's a program that's funded by the Department of Health and Human Services. You can imagine why that may be the case, but we ended up suing the Trump administration because we know that this is not about politics, but about the 20,000 teens who would not be without a critical health resource.
You know, when I was listening to Steve Dixon up here and his book, The Tyranny of Experts, and he was asked by Olga, what did you see was wrong, not working, and he would talk about sort of do-gooders not connecting in a way with the people that need it. I was very moved by that because I see it in lots of places around the country where there are people with heart, people with intent, people who really want to help, and so high on heart, poor on strategy, perhaps poor on results. What do you think can be done to better improve that gap between people who actually do want to move needles as opposed to getting the needles moved for people who need the most assistance?
Yeah, I remember after the unrest when this was back in April of 2015.
This was Freddie Gray.
Right, after the death of Freddie Gray, in police
which you wrote about passionately.
Very much, and one of the things that will always stay with me is that as my team and I were going door to door to get medications and food and other resources that people were asking us for, we got 2 questions. This was April of 2015. The first question we got was, what candidate is this for? Thinking that we're not the health department, but for a candidate. And again, April of 2015, not even 2016. Second question was, what study is this? Because we filled out a survey last week. And our residents weren't trying to say negative things about research or what, I mean, they weren't trying to be cynical or sarcastic, but they were pointing out that they always saw us there for our needs and not for theirs. And so I think a lot of the work that we need to do is recognizing that this is the perception that exists in our community. Even if we're trying to do the right thing, how we do things is just as important as what we do. And we cannot see communities or patients or whatever groups that we're serving as a checkbox. We need to start, I think, also by employing people who are from the communities that they serve, recognizing that these are also the most credible messengers. I mean, one of the programs we run is Safe Streets. And if I stand on the streets of West Baltimore and say, put down your weapons, don't use your weapons, use words. I mean, that's not going to be very effective. But if we have someone who is...
I don't know, I'd be impressed with it.
You can join the effort. But if we hire individuals who are recently released from incarceration, former gang members and drug dealers who have that credibility, and that to us, seeing people as solutions and not as problems, and hiring them to engage in this critical effort is really important.
Do you, I know this can sound like a weird question, but do you have any hero regions out there, any regions that have been in tough circumstances and have been able to so clearly turn it around that they're a useful model for you to look at?
It's a really good question.
Or are you the model that everyone else should look at?
We learn from so many of my colleagues around the country who are in public health and in other places. And I want to, in this conversation, also commend Mayor Catherine Pugh, who is a leader in this. I mean, she actively encourages all of us agency heads to look at the national best practices, to speak to our counterparts across the country, and to innovate and to not be afraid to do so. So, for example, I've learned in the addiction space, I've learned from my counterparts. Rhode Island, for example, has done a lot around addiction treatment, including working with all of their hospitals to start a voluntary levels of care for all hospitals. I mean, it only makes sense, right? Why should we be treating addiction differently than any other disease? Why are there entire hospitals that don't treat something that is as common as diabetes, heart disease, that's killing our residents? And so we adopted that model. We are now working with all of our hospitals here. Now, nearly all of our 11 hospitals in Baltimore are offering buprenorphine medication treatment on demand. We have standardized discharge protocols in all of our hospitals. I mean, these are things that we learn from other places. And under Mayor Pugh's leadership, we recently started a stabilization center, which is the beginning of a 24/7 ER for addiction and mental health, a model that we learned from San Antonio and San Francisco. So I think that we're learning pieces from other places while overall pushing what we know is true, that we can't just be talking about this narrative of choice without recognizing that choice is predicated on privilege, and that public health has a big role to play in leveling that playing field of inequality.
So to that point, a guy named Anthony Fox used to be our Secretary of Transportation, was a mayor, and he took me through a tour once of the United States and showed where infrastructure decisions, where highways were, things had gone on, had basically punctuated the racial divisions in the country, the economic class divisions in the country, and that, you know, told this amazing story of how racism and bigotry had been built and actually sculpted in the reinforcement of that in the United States. Ta-Nehisi Coates, one of our really wonderful writers, has also talked about this legacy of racism. When you're in Baltimore and you're looking at this and you come in the role you are, do these divisions in the past become obvious, and where are we today on a scale of 1 to 10 of undoing that?
I think that, you know, in order to undo so much of what's happened in the past, we first have to recognize it. This manifests itself in a lot of ways, but I'll continue with talking about addiction. I mean, I don't, you know, I was in a community meeting several months ago, and somebody in the back stood up. It was a gentleman in his 40s, and he said, "I need to ask you a question." I said, "What?" And he said, "Well, the president is talking about addiction as a disease. The governor has called addiction and overdose an emergency, but what I don't understand is that there has been a state of emergency around opioids and overdose my entire life in Baltimore. So why is it suddenly an emergency?" And I think we need to answer this question and say that it is an emergency now because there are white people in suburban or rural areas and wealthy people who are dying of this disease. And yes, this understanding is long overdue. But when addiction and overdose affected poor people, minorities, Black and brown people in inner cities, we said it's a moral defect, so lock them up, or if they die, it's their fault. And I think we need to recognize that we have generations of people that we owe an apology to. And unless we can confront those structural inequities and racism, that we cannot move forward in our conversations.
I want to go to the audience. I want to go to the audience in just a moment. We've got mics out there, but just real quick, who's the enemy in your story? Who's trying to keep you from succeeding?
It's hard when it's an on-the-record, live-streamed conversation. Your enemies, right? But you know, there is this pervasive attitude, I think, in understanding of public health, right? That, again, when we're invisible, what's going to happen? If we're invisible, that means that whenever it comes time for funding decisions, public health is the first thing that's cut because it's not immediately seen by others. But what happens if we cut Medicaid? Well, half of our pregnant women depend on Medicaid. And we know that women who do not get prenatal care are 5 times more likely to have babies who die than women who do get prenatal care. And by the way, it's also more expensive because these women are going to give birth to low low birth weight, preterm babies that may end up having longer NICU stays. I mean, this is going to be more expensive for us later, but we're not seeing the effects up front. And that's why things like Flint happen, because somebody decides this is cost savings up front, and nobody is advocating for public health. So I think that, if this is not too much of a cop-out answer, that the enemy, in fact, is all of us. And the solution resides in all of us, too. That we are the ones who we're waiting for. That we are the ones who have to step up and say, this is how health is tied to everything. If you care about, we're in the middle of election season right now, and if you care about jobs, care about the health of your workforce. If you care about safety, think about how health ties into it all. If you care about education, what about the health and well-being of our most vulnerable kids? So we're the ones who have to be that constant cheerleader to make this case all the time. But if we don't, we will be our own worst enemy.
I think that was an outstanding response. Let's go right down here. Yes.
And that's actually a great segue to my question. I work with the National League.
Who are you?
Anthony Santiago. I work with the National League of Cities. And we work with city leaders all the time. And one of the challenges that are constantly identified is, you spoke to this, or alluded to this idea of health in all policies, right? But when you're dealing with your peers who are, and sometimes they're inside city government, sometimes they're county or regional, right? But when you're dealing with your peers and you're thinking about that person who's in workforce, focused on economic development, the last thing in their mind sometimes is health. Same thing in housing, you know, and you can go down the line in the number of departments that connect with your work. You talked about law enforcement. So anyway, long story short, how can you describe to other city leaders to knock down those silos that sometimes exist within these governmental sectors?
It's a great question, and my answer will be similar to what I gave before, which is that we have to make the case every time. We can't expect for everybody else who's not in health to make those connections, because they all have their priorities too. I mean, when I think about, some days when I think about the difficulty of my job, I think about what is the police commissioner going through, or what is the our superintendent and CEO of city schools going through. And we all have challenging jobs. But our role in health has to be that the person, the constant voice to say, for example, with education. One statistic that shocked me when I first came to the city was that up to 10,000 of our kids don't have something as basic as eyeglasses. I mean, I wear contacts and glasses, and many of you wear glasses I see in this room, and I believe in research, but how many more studies do we need to show that if you can't see, you can't read? And so we worked with city schools, we worked with Johns Hopkins as a partner, Able Foundation, Casey Foundation, others sponsored our work to get glasses for every child. I mean, that's a simple intervention we can make that makes a big difference, that ties into education, and we need to show those successes all the time, and the importance of the work all the time to our fellow agency heads and other leaders across the city.
Yes, I think we have a question over here.
Thank you. I'm Kitty Shide, and I'm also with the National League of Cities, but I did not coordinate this with Anthony. But Dr. Wen, you are the type of leader that who is audacious and who sees beyond your immediate scope of direct authority. One of the issues with the fact that we do have tremendous savings if we do the right thing is the wrong pocket issue. You know, where the money is saved isn't always where the money needs to be invested.
Right.
And it seems like we need a higher level of leadership, which I think you model, but I wonder if you could put that into a secret sauce
how do we clone you?
For us.
I think it's a great question, you know, in terms of dealing with misallocation of resources and where things are. So how have you fixed that?
I don't think I have, actually. So don't clone me. This is something for you all to solve, not for, because we haven't figured it out here. You know, we thought about this a lot when here in Baltimore we were going through issues with funding around Safe Streets. Safe Streets, this program has 4 sites across the city, the outreach workers mediate 1,000 conflicts a year. Independent studies have found that 80% of those conflicts, 80% of those conflicts were likely or very likely to result in gun violence. Huge costs of gun violence, right? You can imagine what those are. They're medical costs, cost of incarceration, retaliation, economic. I mean, there are huge costs, but those cost savings aren't realized at the same places as would be investing these funds for Safe Streets. I haven't been able to make the case for how can we connect city, state, federal funds, medical costs, law enforcement. I haven't figured it out. I mean, I'm very lucky that, again, our Mayor Catherine Pugh, really believes in Safe Streets and has committed to expanding Safe Streets from 4 to 10 sites in our city, which is amazing. But figuring out how to connect those economic pieces, I'm not sure. I think that in the meantime, though, I mean, just as fixing racism or poverty, I mean, these are longer term issues. But what we are focusing on in the city is, where is the impact that we can have right now? What can we do right now with the resources that we have? Because we cannot wait for others. I mean, there are things that are within your sphere of influence. This issue, not entirely within my sphere of influence. I can try, but I can't make it work. So what is within our sphere of influence that we can impact right now? Can
I just wrap up? You wrote this powerful piece after Freddie Gray's death. Has anything major structural changed in this city that it's realized that it had to change after Freddie Gray?
There is, and I'll give you one specific example of that. We have had an opportunity to address mental health and trauma in our city in a very different way than we've had before. We were able to obtain a grant under the previous administration from the federal government to specifically address trauma in West Baltimore. And we did this work with this coalition for this grant. It's called Recast, very differently. We said, look, who are we to talk about the experience of trauma in the community? This was something the community, by the way, pointed out to us and said, look, you got this fancy grant on trauma, you have all these resources, but where is that really going? And why are you coming here to us telling us the experience of trauma and telling us what works? So we decided that we were going to elect a community board, and the community board was going to make the decisions about where the resources were spent, how this was going to be operational. And I think this idea of doing work differently, as frightening as it is a contribution that we have made and a commitment to the work that we're doing post Freddie Gray.
Thank you. So I finally get what Olga Kazan meant about the firecracker. Commissioner Leana Wen, thank you very much.